Hello, in today's video we will be covering depression, how to recognize it, pharmacological and non-pharmacological management, and we will also cover some NCLEX questions and what you can expect to see on exams. Make sure you hit that like and subscribe button right now. All right, let's try this again. So funny story, not so funny. This is my second time around recording this because there was a glitch the first time. So let's get started. Major depressive disorder. The important thing to know in this section is it's okay to get sad once in a while. If you are going through a situation, maybe your dog died or something, it's perfectly normal to feel upset. That is not depression. Depression is a persistently depressed mood for a minimum of 2 weeks, loss of interest or pleasure in things that you used to find pleasure in, and we call that anhedonia. Weight loss or gain, insomnia or hypersomnia, so you're either not sleeping or sleeping all day. Fatigue and feelings of worthlessness or excessive guilt. The admission note indicates a patient diagnosed with major depression has inertia and anhedonia. For which measures should the nurse plan? Select all that apply. So remember, when you're reading a question in nursing, look for your keywords in the question stem. And the keywords here are depression, inertia, and anhedonia. This is how their depression is manifesting. They have no energy and they have lack of pleasure. So if they have no energy, are we going to channel excessive energy? No, because they don't have that. It says reducing guilty ruminations. Now, ruminations is something that occurs in depression, but is that what is being talked about here? No. Instilling a sense of hopefulness. Yes, there's a lack of pleasure, so we need to get them hopeful. Assisting with self-care activities. Yes, because they have no energy. And accommodating psychomotor retardation. Yes, their motor skills are going to be slowed down, so we need to accommodate for that. So the answers in this section are going to be C, D, and E. What are the primary risk factors for depression? It's having a female gender. There is a consensus that there is a hormonal component to depression. Adverse childhood experiences, so anything like sexual abuse or physical abuse. Stressful life events. First degree family member with MDD, there is a genetic component to depression. Neuroticism. Essentially what neuroticism means is someone that is not easygoing or laid back, someone that needs to control everything and everyone. So when someone is really neurotic, that need to control everything can lead to depression. Substance abuse, so cocaine, alcohol, all those things. Anxiety and personality disorders can sometimes lead to depression. And chronic or disabling medical conditions, there is a kind of a vicious cycle between pain and depression. Unfortunately, when someone is depressed and they feel pain, pain is heightened. Their perception of pain is heightened in depression. But on the other hand, pain can also cause depression because it's not pleasant to be in excruciating pain 24 hours a day. And that can also sometimes lead someone to get depressed if they weren't going to have depression. And for example, my predisposition primarily is to be a happy person, but I have interstitial cystitis, which is a painful bladder condition, and sometimes that flares up, and I'm not a happy camper when that. And then, there's just been other issues that I've had that when I'm in pain, it's really hard to be in that good mood that I usually am in when you're experiencing pain. So definitely pain can contribute to depression. Once again, risk factors for depression, there's a genetic component. There's a 50% concordance in identical twins. There's a biochemical factor. They have shown that, individuals may not have enough serotonin or may not have enough serotonin, or their body is not making enough serotonin and norepinephrine. Estrogen may contribute to it. That is one reason why when women start on birth control, we always ask if they have a history of like suicidality, or if they notice that their mood is changing drastically, to please come back into the office. There may be an inflammation component, and there may be elevation in inflammatory biomarkers. Events So the life events plus genetics can also lead again to depression. So that comorbid factor, not one thing causes depression, but kind of like the perfect storm, everything coming together. Disturbed cognition, sometimes they will have feeling of worthlessness. One of the main things that you need to master in mental health, if you're watching this for nursing, is the fact that safety is the number one priority. And kind of this little three-step process here. So assessment of suicide potential. I'm going to create a different PowerPoint on suicide, but inevitably sometimes depression can lead to suicide. And that is the ultimate thing we were trying to avoid at all costs. So you always, every shift, or when you're, if you're a mental health nurse, or if you are taking an exam, we're always assessing for suicidal ideation. And all that means is, are you having thoughts of suicide? Are you thinking of hurting yourself? Are you thinking of killing yourself? So you always want to assess for suicidal ideation. And that's where you would say, are you having any thoughts of harming yourself or killing yourself? If they say yes, then the follow-up question would be, do you have a plan? Do you have, for example, if someone says, yes, I'm having thoughts of killing myself and I'm going to shoot myself in the head. So they have a plan, and then the follow-up question is, do you have the means to carry out that plan? So do you have access to guns? Yes, I have a closet full of guns. And there have been situations where this has happened. And then what the psychiatrist says is this person cannot be discharged until those guns are removed from that environment. Because when you see the PowerPoint on suicide, the risk factor, the number one killer, the way that people kill themselves is through guns. That's the number one way that people are able to kill themselves. It's not overdose, it's not hanging, it's not jumping off bridges, it's guns. Suicidal ideation is a major contributor to hospitalization, and some of the therapeutic communication could go along the lines of, when you feel depressed, what thoughts go through your mind? Have you gone so far as to think about taking your own life? Do you have a plan? Do you have the means to carry out your plan? Is there anything that would prevent you from carrying out your plan? Key assessment findings in depression. Once again, depressed mood, anhedonia, anxiety, dwelling and exaggerating on faults and failures. So for example, let's say someone is a straight A student and they've been a straight A student their whole life and they got one B. And they're like, oh my gosh, I'm such a failure. I can't believe I got a B. Everything's down the drain. I'm worthless. Or the straight A student that goes into nursing school expecting to maintain straight A's and they get a B or a C and it's the end of the world. But all the other A's that they had got prior to that are discounted. Just dwelling on your faults as opposed to thinking about your strengths. They're unable to focus on their strengths or successes. And once again, that chronic pain is a two-way interaction. So when people are in pain, that can lead to depression. But then when they're depressed, that results in their pain being heightened. So it's even worse than if they weren't in pain. And I really feel for people that have chronic pain because it's not easy. It's easier said than done. If you've never experienced excruciating pain, you have no way of relating to these individuals. So please be kind to these individuals. Don't judge them. Don't call them med seeking or any of that. It's so easy. I see many people become cynical after they've been nurses for a while, and it breaks my heart. Like, if you're cynical and you're burned out, then move to a different unit, then work in the OR. I don't know. Do something where you are not treating patients negatively, because it's uncalled for and it's not professional and it's not the right thing to do. A client notifies a staff member of current suicidal ideations. Which nursing intervention would take priority? Are we going to place the client? So once again, keywords. They're having current suicidal ideations. So what did I say was the follow-up if they're having thoughts of suicide? Are we going to right away put them on a one-to-one observation? And what is a one-to-one observation? That is basically when someone is so either homicidal or suicidal that they need a shadow, is what they basically are. That is someone that is within arm's length away from them at all times, watching them, observing them, that they are not going to hurt other people or that they're not going to hurt themselves. Believe it or not, I worked with a client so dangerous once that he was on a 2-to-1, not because he was going to hurt himself, but because he was going to hurt others. The answer to this question is determine whether the client has a specific plan to commit suicide. Once again, all the answers sound great, right? But you have to know the playbook in mental health. And the playbook stipulates that same 3-step process. First, we ask, do you have thoughts of suicide? Do you have a plan? Do you have the means? And that's kind of what you have to stick to. And here we go. Determine whether the client has a specific plan to commit suicide. Areas to assess. What's their affect like? The affect is the person's outward representation of their inner emotional state. Do they have a flat affect? Do they have monotone speech? Do they convey sadness and dejection? Think of Eeyore. Everything is bad. And today the sun is out, but it's gonna rain tomorrow, and I have no energy, and I'm gonna go sleep all day, and I'm just gonna eat because there's nothing else. There's nothing else I wanna do, right? So gray colored glasses, think of Eeyore. Eeyore is gray, gray colored glasses, that's seeing the world like Eeyore. Everything is so awful. They may have poor posture, they may look older, and they may just start crying out of nowhere. Sometimes all it takes is to ask one key question, and that just triggers something, and here come the waterworks. So frequent bouts of weeping, hopelessness, and despair. Which symptom is an example of an affective alteration exhibited by clients diagnosed with severe depression? So what are we looking for? We're looking for affect, which is the mask-like face. So if it has anything to do with behavior or thought process, we can eliminate it. The only one that shows what the mask would look like is apathy. Apathy is like, I don't care about anything. Everything's awful. I won't smile. This is me. I'm apathetic. I'm withdrawn. So apathy is the answer. Somatic delusion. A delusion is a distortion of thought, right? Distortion of cognition. Difficulty falling asleep. Yeah, that can be a symptom of depression, but it's not an affective alteration. So when you're taking these exams, you have to look for key words. I cannot emphasize that enough. Okay, what is their thought process like? They're going to have impaired problem solving, impaired decision making. They're going to be indecisive, poor memory and concentration, intrusive negative thoughts. And that's kind of what we call rumination, just thinking over and over and over again of negative things that have happened. That's kind of how, this is my Bitmoji. I introduce you to my Bitmoji. And that's kind of how they're going to be. They're going to be like sunken and I'm sorry and poor eye contact and feeling dejected. So feelings, you can just kind of get their demeanor. They just exude this feelings, worthlessness, guilt, helplessness, hopelessness, anger. I am no good. I'll never amount to anything. Negative ruminations. Depression is not only thinking, right? There's other factors to it, and there's neurochemical imbalances that they say, right? But who wouldn't be depressed if constantly running through your mind is, I'm no good, I'll never amount to anything, I'm so ugly, I'm so fat, or I'm so skinny, or I have a big nose, or whatever. So of course these people are going to be depressed if constantly this is what they're telling themselves in their head. And unfortunately, many times they are taught this. They're taught this by their parents, and this has been something that I have tried hard to overcome because I have a very hypercritical father where he nitpicks everything. For example, just the other day, I wore a dress that I love and it looks great on me. You know what he says? Instead of saying like, wow, that's a great dress or that's a pretty dress. No, that dress is old. When are you going to go shopping? When are you going to buy a new dress? So overcoming that kind of upbringing, it's hard, but it's possible because I refused to let his criticism become my internal voice. And a lot of times that is what happens, unfortunately, with these individuals. They're criticized. Like, for example, it breaks my heart when I hear parents tell their children, "What's the matter with you? Are you stupid?" You should never talk to your child like that. Never. Never call your child stupid. You know what happens when they grow up? That voice becomes internalized. That becomes their internal voice. And that is not okay. And that is not acceptable. So I urge you, please be kind. If you have kids, be kind to your children and don't belittle them. So, and if you were belittled as a child, we're adults now. We can overcome this. That's why cognitive behavioral therapy is so important and is such an effective technique that is underutilized in depression. So there's my soapbox. I'll get off of it. But if you have depression, don't just rely on medication. Yes, medication is important, but what about trying some therapy and medication? It can do wonders. A patient became severely depressed when his wife left him. The patient repeatedly says, "No one cares about me. I'm not worth anything." Which response by the nurse is the most therapeutic? Okay, here's another pearl for you in mental health. In mental health, you don't want to give basically false hope or say everything's going to be okay, everything's going to work out, because we don't know that. We can't give false reassurance, right? Number two, you cannot. It is considered non-therapeutic. That is the non-therapeutic technique of making an approval or disapproval statement. You cannot tell people anything like, "I like your shirt, I like your hair, you're so pretty, blah, blah, right?" That is considered the non-therapeutic technique of approval or disapproval. Now, this is textbook world. In real life, are you going to see therapists, doctors, nurses telling a client, "Oh, wow, that's such a pretty picture you drew," or "that shirt looks great on you"? Yes, you will, okay? But for textbook world, you cannot give these individuals compliments. That will not be the right answer on an exam, okay? So looking at this question, which response by the nurse is the most therapeutic? Keyword here is they're looking for a therapeutic answer. So things will look brighter soon. Everyone feels down once in a while. That's false reassurance. Bam, cross it out. Our staff members care about you and want to try to help get you better. You can't talk about other people. You can only talk about yourself, right? We don't know if other staff members really do care about this person. In an ideal world, they would, but we don't know that. Boom, cross that one out. It is difficult for others to care about you when you repeatedly say the same negative things. No, that sounds like you're blaming that person for. Also, in mental health, blaming the client will never be the right answer, which is what number 3 is doing. So the best answer is number 4. I'll sit with you for 10 minutes now. You're setting limits, and 10 minutes after lunch to help you feel that I care about you. Just offering yourself is considered therapeutic, and telling them you're going to be with them for 10 minutes now, and 10 minutes later, you're setting limits and you're telling them that you care about them. Cognitive changes that happen in depression. Negative expectations for the future. Again, another word for that is hopelessness. They don't feel that things will ever get better. So for example, maybe someone, let's say, recently got diagnosed with diabetes, right? And instead of saying type 2, not type 1, and a person that doesn't have depression is going to take charge of their life. They're going to say, "Okay, what do I have to do for diabetes? I got to lose weight. I have to start eating healthier. I am going to stop smoking." They're going to take charge, right? Someone that has depression will say something may have negative expectations for the future. So they'll say something like, "I have diabetes now. I'm going to lose both legs. I'm going to be on insulin forever, and I'll end up on dialysis," right? Same diagnosis, 2 different thought processes can lead you in 2 different directions. Loss of control over future outcomes. Again, the person that got diagnosed with type 2 diabetes says, "I have control. I can do something about this." The person that has a faulty cognitive thought process thinks, "Well, this runs in my family, so there's really nothing I can do about it. I just have bad genes." It may run in your family, but there is something you can do about it. Passive acceptance or futility of planning to achieve goals. So they just kind of accept, they don't make any goals. They just accept the lot they have in life and they don't make any plans. Emotional negativism. They may have despair and despondency, and this is why a lot of times they will engage in substance abuse because they're either trying to numb or self-soothe a pain that is inside of them, or they're angry at themselves and they're doing self-destructive behavior. So the anger may be self-directed or other-directed. If it's self-directed, they're like, man, I'm so stupid, I'm so worthless, right? And they may engage in substance abuse because they don't care about themselves, they don't care about their body. So for example, when you have a healthy self-esteem, you love your body so much that you don't want to do anything harmful to it. And if the anger is directed towards others, they're going to be hypercritical. They're going to be belittling, demeaning. Oh, you're so stupid. Why did you do that? Or someone cuts them off on the side of the road. Mother, right? I'm sure you all know people that the slightest mishap sets them off like it's World War III, right? Those are people with an underlying issue, perhaps depression. Nothing should set you off like a firecracker, right? So they may engage in self-directed anger, they may engage in alcohol, substance abuse, binging, or smoking, and other directed, they're very angry, irritable. They could use sarcasm as a weapon to put down others, or they may be very passive aggressive. So yeah, self-assessment. Mental health exams love the self-assessment portion, and the question will be something along the lines of like, before the nurse can take care of a depressed client or of a borderline patient or of a homeless patient or of a substance abuse patient, what must the nurse first do? And it's always going to be something along the lines of like, examine your personal feelings. What the test makers want you to recognize is, do I have any personal bias that's going to make me treat these people poorly? And you need to be able to be aware of that, because if you're not aware that you're biased, that, for example, you have prejudice against homeless people, then you may act in an unprofessional manner towards this person without even knowing it. You always want to recognize unrealistic expectations for yourself or the patient. So, for example, a goal, and it would not be an appropriate goal for you to say that by the end of my shift, the patient will be cured from depression, right? That's not a SMART goal. It's not a specific, a measurable, attainable, realistic, and timely. A SMART goal would be, by the end of my shift, the patient will be able to identify 2 positive coping strategies. Identify feelings the patient may be experiencing. Remember, be empathic, not sympathetic, like, oh, bless your heart. Oh, I feel so sorry for you. Oh, yes, but I mean, my life is great, but bless your heart. No, like, be be in there in the trenches with them, like help them. Don't be up here looking down on them. Get to their level. And I don't mean like literally eye level, but what I mean is like be on their emotional level. People know when you're just being patronizing, like, oh, poor you, I feel so sorry for you. Then, wow, that's really hard that you're going through that. I am so sorry. Is there anything that I can do for you? Understand the role that genetics and biology play in depression. So, for example, some people don't think that depression is real. Some people are very blessed with, my mother is the most optimistic person I've ever met in my life. Like anything could be going wrong and she always turns it around and she's so optimistic. Some people are blessed that way. But then just because she got good genetics, we can't blame someone else for their depression. We can't say like, well, just think yourself out of that, or depression's not real, or we have to understand that there is a genetic and a biological component in depression, and that in that way we can be more patient with these patients. And again, examine your personal feelings. NANDAs. Appropriate NANDAs for depression. Safety is the #1 priority, so risk for suicide, right? It could be self-directed violence or risk for self-directed violence, ineffective coping, social isolation, hopelessness/powerlessness, spiritual distress, chronic low self-esteem, self-care deficit, insomnia. Communication guidelines, if they're severely withdrawn. You want to use the therapeutic technique of making observations. So making an observation would be if someone hasn't left the room or never gone to group, saying something like, I noticed you went to group today. Remember, we're not saying like, good job, you went to group today. That's considered non-therapeutic in mental health world. You want to use simple, concrete words. We don't want to say a stitch in time saves time, right? We say things like, okay, let's plan your day for tomorrow, or this is the plan for tomorrow. Breakfast is at this time, group is at this time, blah, 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 right? Very simple, concrete. Allow time for the patient to respond. If they're depressed, they may have lack of energy, which is inertia, and we don't want to talk over them. So if you're talking to them and you're like, blah, 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 right? Blah, 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 right? No. The therapeutic technique of silence is so important in mental health. If sometimes you just sit with them, boom, they will just verbally vomit all this stuff on you. And then people will be like, wow, how did they tell you all that? I just listened. Listen for covert messages and ask about suicide plans. So if they say something along the lines of things will get better soon, or they start giving away their possessions, or they'll be sorry they did this to me, things like that. Those are covert messages. Avoid platitudes. You don't want to say things like everyone gets down once in a while. It minimizes their feelings and it may increase their guilt. Like, you should be grateful. You have so much. Think about the children in Africa that have nothing to eat, right? What's that? You're just making them feel guilty. That's making them feel worse. Here we go. A patient diagnosed with major depression says, no one cares about me anymore. I'm not worth anything. Today, the patient is wearing a new shirt and has neat, clean hair. Which remark by the nurse supports building a positive self-esteem for this patient? So are we going to say, you look nice this morning? No, because like I told you, that's the non-therapeutic technique of an approval or disapproval statement. Are we going to say, I like the shirt you are wearing? No, again, that's the non-therapeutic technique of making an approval statement. You must be feeling better today. That's kind of making an assumption, and we know what happens when you make assumptions, right? And you're wearing a new shirt. That is the therapeutic technique of making an observation. So B is your right answer. Interventions that you can do as the nurse is help the patient identify cognitive distortions such as overgeneralization. And let's say that the patient is a nursing student and they just failed a semester in nursing school. And they're like, I'm such a failure. I always fail at everything. A way to challenge this distortion is to say, and again, when I say challenge, I don't mean like argue, never that, but kind of tell them like, well, you failed this semester, but how many other semesters of school have you passed? I mean, you got through elementary school, you've gotten through middle school, you've gotten through high school, you got through your first semester of nursing school. This is just one semester. This is the only semester that you've actually failed. So by your logic, you are not a failure because you've only failed one semester and you've passed however many semesters. Help them identify when they're self-blaming, like, I'm so stupid, I always mess up. Or mind reading. Mind reading is something that is also very unhealthy that a lot of people engage in. I've heard a lot of my girlfriends will say something like, well, if he really loved me, he should just know that I need him to do this, or he should have just known to do that. We are all very different. We are all very different, and people are not like us, and we can't assume that they behave like us. And if you want someone to do something, you have to ask them. People are not mind readers. So that can create a lot of conflict, this cognitive distortion. Discounting of positive attributes, and you want them to identify positive coping skills such as exercise, supportive relationships, and therapy. And several studies, several randomized control trials have shown that cognitive behavioral therapy and exercise is almost as effective as medication for mild depression. Now, when you get into like your severe depression, you need to get medication to kind of get you kickstarted and get you out of that rut. But if you're feeling like you're headed down towards that depression slope, do something about it before it gets worse. So seek help, talk to a therapist, start exercising, join a support group, something. When these individuals are on the unit, once again, our major concern is safety. So they're going to be on suicide precautions, and safety becomes a priority on the unit for individuals at high risk for suicide. So we want to remove all harmful objects. We want to make sure that they're not going to use anything to strangulate themselves. So we're removing belts, we're removing shoelaces. Depending on the unit where you work, you may have more or less strict regulations. Where I used to work, if people were highly suicidal, we would put them in paper scrubs, because if they tried to hang themselves with the paper scrubs would tear. Medications, obviously, we're removing medications on admission because we don't want them overdosing on these medications. Again, on the unit where I used to work, it was an acute care unit. We would pat them down. We would remove all of their possessions, put them in a bag, put them in a locker, and they would not have access to those possessions until they were discharged. But if they're in a normal unit, you don't want them to have access to medications. Interventions for vegetative signs of depression. Anorexia, you want to offer small, high-calorie, high-protein snacks frequently throughout the day. You want to offer high-protein fluids. Insomnia, offer periods of rest after activities, encourage relaxation measures. Self-care deficit, encourage the use of a toothbrush, washcloth, soap, give them step-by-step reminders. Wash the left side of your face, now the right. Constipation, monitor intake and output, offer foods high in fiber, and encourage fluids. And vegetative signs of depression, think of when someone's in a vegetative coma, right? They're just existing. They're just a body there. So this kind of depression almost mimics that. So that's why they need the very concrete step-by-step instructions. A patient with major depression shows vegetative signs of depression. Which nursing actions should be implemented? Select all that apply. And okay, so it's a select all that apply, and they're showing vegetative signs of depression, which we did mention. Offer laxatives if needed. Do they suffer from constipation? Yes, the previous slide said they do. And they're not really intaking too much, so we want to monitor food and fluid intake. Provide a quiet sleep environment. If they're going to have insomnia, yes. Eliminate all daily caffeine. Well, they don't really have energy, so why would we eliminate caffeine? It might actually give them a little bit of energy. And then restrict intake of processed foods. This is one where it sounds good, but it's not addressing the question. Are processed foods good? No. But does it have anything to do with vegetative signs of depression? No, not really. So your answers are going to be A, B, and C. Okay, now we get to the nitty-gritty of it. Antidepressant drugs. They target sleep disturbance, disturbed appetite, fatigue, decreased sex drive, especially bupropion or Wellbutrin, psychomotor disturbances, anhedonia, and impaired concentration. So this little mnemonic for selective serotonin reuptake inhibitors, by the way, SSRIs are usually the first-line treatment in depression. That means we will try these drugs first before we try others. And the mnemonic for this one is, for extra sleepy clients, please. So F for fluoxetine, E for escitalopram, S for sertraline, C for citalopram, P for paroxetine. Once again, these drugs are usually the first-line treatment in depression. It may take 1 to 3 weeks for improvement in mood. And unfortunately, this is a big obstacle for clients because we live in an immediate gratification society and we want to take a pill and we want to see the effects right away. So having to wait 1 to 3 weeks is a major reason why patients start taking meds and then just stop, and why they're not medication compliant. Another thing that we want to watch them for is, because it takes so long to kick in, what happens is that they start taking this pill, the therapeutic effect, their mood is still depressed, but they get a little bit of an increase in energy, but they're still suicidal. So now before they were lethargic and they were like, I have no energy. And now I'm like, I have energy, but I still feel crappy. So now they have the energy to carry out their suicide plan. So we want to when they first start taking their drugs, we want to monitor them for suicidal ideation, potential for killing themselves, and they love to ask that on mental health exams. How it works, it blocks the reuptake of serotonin, right? Selective serotonin is selective only to serotonin, reuptake inhibitor. So it inhibits the reuptake of serotonin. That's all it's doing. Pretend that here's a little serotonin molecule and it was going to be taken up and oops, something blocked it from getting up. Here is an empty receptor. Here comes the pill and it blocks it, so serotonin can't be taken up anymore. And it's like, okay, so now we have more serotonin floating around here. Side effects of SSRIs include agitation, insomnia, headache, sexual dysfunction, hyponatremia. Warnings: don't discontinue abruptly, taper down slowly, monitor for serotonin syndrome, it can be life-threatening. A patient should discontinue all SSRIs for 2 to 5 weeks before starting an MAOI. And we wanted to monitor closely when they first start taking their medications because of the black box warning, and Paxil has a black box warning describing basically what I already told you. And here it is. Suicidality and antidepressant drugs. Antidepressants increase the risk compared to placebo of suicidal thinking and behavior, suicidality in children, adolescents, and young adults in short-term studies of major depressive disorder. So once again, that will be on an exam. Serotonin syndrome, you need to know this, okay? Just like, so when you take the NCLEX, the number one goal for them is to make sure that you are competent nurses, that patients are not going to die on your watch. So in mental health, a lot of these meds have life-threatening side effects. The life-threatening side effect for antipsychotics is neuroleptic malignant syndrome. The life-threatening side effect to SSRIs is serotonin syndrome. The life-threatening side effect to MAOIs is hypertensive crisis. So, serotonin syndrome. What happens? Too much serotonin in your body. Because you started taking this, it blocked the reuptake, and all of a sudden, too much serotonin. And in the body, everything is a balance, right? Too much of something is not good. So symptoms of serotonin, how to recognize it: hyperactivity, restlessness, tachycardia, fever, elevated blood pressure, altered mental status, abdominal pain, diarrhea, apnea, death. Interventions, you want to remove offending agents, so stop the med. Symptomatic treatment, we're going to treat the symptoms. We can offer them a serotonin receptor blockade, which cyproheptadine or propranolol. Normally, they don't test you on this. You need to know how to recognize it. Cooling blankets, you can give dantrolene or diazepam for muscle rigidity or rigors, and they may need artificial ventilation. A patient being treated with paroxetine, 50 milligrams orally daily for depression, reports to the clinic nurse, I took a few extra tablets earlier today and now I feel bad. Which assessments are most critical? Select all that apply. Okay, paroxetine, what is it? It's an SSRI, right? For extra sleepy clients, please, P, paroxetine. So they took a few extra. We're worried about serotonin syndrome. How does serotonin syndrome manifest? That's how you need to answer questions on an exam. We identify the med, what's the class, what are the adverse effects from it. So they can get tachycardia, right? They can get hypertension. So vital signs. Did it mention anything about urinary frequency? No, it mentioned GI symptoms. Did it mention anything about psychomotor slowing down? No, it actually mentioned restlessness. So we're going to do vital signs. GI symptoms, right? It did say abdominal pain and diarrhea. So we're going to go with diarrhea. Hyperactivity or feelings of restlessness. Notice how this one is the opposite of this one. So it can't be both because they cancel each other out. So if it's not this one, you have to go with this one. This is the SNRIs. So these inhibit the reuptake of serotonin and norepinephrine. And we have desvenlafaxine, duloxetine, levolmilnacipran, and venlafaxine. Duloxetine helps reduce pain associated with depression and is approved for fibromyalgia and diabetic peripheral neuropathy. So you may see it used frequently, aka Cymbalta, frequently for this neuropathy pain and in people with fibromyalgia. A severely depressed sullen adolescent. So here's the keyword: severely, right? Patients don't just go from severe depression to bouncing back and being Tigger, like, woohoo, yes, that was what I needed. I'm all better now. So a severely depressed, sullen adolescent has been taking fluoxetine for 10 days. How long did we say it takes for this med to kick in? We said 1 to 3 weeks. During a follow-up visit, the client smiles euphorically and states, I feel so much better now. How might the nurse interpret this behavioral change? The fluoxetine has potentiated serotonin syndrome? Not really, because serotonin syndrome doesn't make people feel high. The medication dosage should be decreased. Well, it hasn't really had time to kick in yet, so how are we going to start increasing it or decreasing it? The client's behavioral change is normal and expected. The client may have decided to carry out their suicide plan. Remember when I told you that they love to test on this? This is an example of that. So the thought process is also that if someone is debating between killing themselves or not killing themselves, that is pretty heavy stuff. That is a pretty heavy load to be carrying on your shoulders. So they're having all these conflicting thoughts like, I'm so depressed, life is not worth living anymore, but what will my parents, I don't want to do that to my parents. I don't want to do that to my sister. I don't want to do that to my girlfriend. But I'm just so depressed. I just have so much pain. I just can't live with this pain anymore. When they finally make that decision of, you know what, I'm just gonna, I'll leave a note, I'll apologize, and I'll make sure that they know this had nothing to do with them, and I'm just gonna follow through with it. What happens is, because that decision has been made, all of a sudden they feel like, whew, a weight was lifted off their shoulders. They're not debating this life-altering decision anymore. And when someone is indecisive about something and finally makes a decision, they actually do experience a sense of relief. Like, okay, well, I made up my mind. This is this, and I'm going to go through with it. So the answer is 4. Additional antidepressants include trazodone. You may see this prescribed a lot. A lot of times what they're prescribing it for, even though it's an antidepressant, they're prescribing it for sleep. So people that are unable to sleep, they're using this as a sleep aid. And that's why, because it has significant sedative effects. You want to watch for sedation and hypotension, and priapism has been reported, although I must say it's rare because I've never seen it. When I was working as a mental health nurse, priapism is a prolonged painful erection that just will not go down. Bupropion, it blocks the reuptake of norepinephrine and dopamine. It may reduce appetite. It may increase sexual desire. It's used as an aid to quit smoking, and they love to ask that. And high doses increases seizure risk. The thing about bupropion or Wellbutrin is that it actually doesn't cause ED issues or desire, a decrease in libido. Unfortunately, some of the SSRIs do decrease libido or cause ED, which is the actual erectile dysfunction. And mirtazapine, side effects include weight gain, appetite stimulation, sedation, dizziness, and headache. Mirtazapine would be good to prescribe to someone who's depressed and is not eating very much and has lost a lot of weight, and this is something we actually want to give them to help stimulate their appetite. So if this is almost an anorexic client that's lost 30 pounds and they're way below their weight, then maybe this would be a good agent to think about. TCAs, tricyclic antidepressants, they inhibit the reuptake of norepinephrine and serotonin. They're not prescribed very often anymore because they're very lethal. That's primarily what you need to know with that. They can cause orthostatic hypotension and dry mouth and all that, but they're lethal in overdose. So we would not prescribe TCAs. A test question you may see is someone who is highly suicidal. We wouldn't give them a 90-day supply of amitriptyline, right? That would make no sense because they could take even half of the 90 and kill themselves. So these are very rarely prescribed anymore. once again, and she's like, pay attention to me. What you need to know about TCAs is that they're lethal in overdose. They can cause orthostatic hypotension. They are contraindicated in narrow angle glaucoma or history of seizures. Just memorize these three because there's only three of them and you need to know them. Phenelzine, seleglene, and tranylcypromine. These are monoamine oxidase inhibitors, the MAOIs, as you will most likely see them. And how these work is that monoamine oxidase is an enzyme, and these inhibit that enzyme, the breakdown of that enzyme. Unfortunately, with MAOIs, they interact with everybody. Let's think of MAOIs as that person at work that just doesn't get along with anybody. That's your MAOIs. So with MAOIs, they can't take any tyramine. Think of Tyra gets mean. So we'll say Tyra is the coworker that does not get along with anybody. She's the MAOI. Tyra gets mean when she takes tyramine. So what is tyramine? It's found in foods such as anything aged, basically. Avoid aged, cured, or ripened foods. That's your keyword. If you can ask yourself, is this food aged, is it cured, or is it ripened? If your answer is yes, this person cannot have it if they're taking an MAOI. So taking tyramine plus an MAOI equals hypertensive crisis. They also need to avoid over-the-counter cold medications that contain ephedrine, phenylephrine, or phenylpropanolamine. And they also interact and they can also cause hypertensive crisis because a lot of these things cause vasoconstriction. And then in turn with the vasoconstriction, you get an increase in blood pressure. Routine monitoring of blood pressure during the first 6 weeks of treatment is necessary for both hypo or hypertension. And after an MAOI is stopped, instruct the patient that dietary and drug restrictions should be maintained for 14 days. Hypertensive crisis is your life-threatening condition that can happen. With MAOIs, remember SSRIs, it's serotonin syndrome, antipsychotics, neuroleptic malignant syndrome. So they can get severe high blood pressure that can lead to a CVA. And this is just in general dangerous side effects of high blood pressure. You can get a heart attack and heart failure, stroke, narrowing of blood vessels in the kidneys, plaque buildup in arteries. Foods that you cannot eat if you are on an MAOI. Fermented, right? Aged cheese, meat, poultry, and fish. No salami, mortadella, no bologna, no vegetables, fava or broad bean pods. No soy sauce or soybean condiments. And perhaps the most sad of all, sad face, is you can't have any avocados. And I love avocados. So you can't have avocados, fermented bean curd, fermented soybeans, soybean paste, ripened bananas, fermented meats, bologna, pepperoni, salami, fish, dried or cured fish, fermented, smoked, aged, foods with yeast. So you're getting the point, right? Do you see why these are rarely prescribed? Because they have so many interactions. If these were to be prescribed, it would have to be someone that doesn't mind eating plain Jane diet and that they're extremely medication compliant and very intelligent and aware of what they can and cannot do. But like I said, rarely will these MAOIs be prescribed, but yet we're still seeing it on exams, on the NCLEX and all that. Foods that are vasopressors that are also off limits are chocolate, fava beans, ginseng, and caffeinated beverages. All right, let's see if you grasped the concepts. A client on an inpatient psychiatric unit has been prescribed chanocyloprine, 30 milligrams daily, which client's statement indicates that discharge teaching has been successful. Okay, can they have liver and fava beans? No, that's organ meat. Chicken teriyaki with soy sauce. Can they have soy sauce? No. Can they have bologna and cheese that's aged? No. Can they have banana? No. Can they have cola, caffeine? No. So what is the answer? It is 3. I'm creating a hamburger with lettuce and onion, potato chips, and milk. Keep in mind that the milk is not aged, it's fresh milk, so it's not like this cheese here. They can have dairy as long as it's not aged cheese. That's why I said The keywords are fermented, aged, or cured. And lastly, we will be discussing electroconvulsive therapy. Thank you so much for sticking through to the end. It's very humane. You do need to obtain consent before you do it, so that would be a test question. Or it might be make sure consent is signed, because in real life, you're going to see that the nurse is often getting consent, but in textbook world, the doctor should be getting consent, not the nurse. So don't bring that real life into here. Doctors should get consent for textbook world and test taking, but the nurse needs to make sure that the consent is signed. And electroconvulsive therapy, a lot of times a general anesthetic and a muscle paralyzing agent will be used. They can get a total of 2 to 3 treatments per week for a total of 6 to 12 treatments. It's very effective for the acute treatment of depression. They will use it for the treatment of depression that has not responded to any other pharmacological management of it. The patient may have retrograde amnesia, they may be disoriented or confused, and they may have a loss of memory, but this is only short-term memory. I was watching, Jane the Virgin, and they said that they gave, and I'm sorry if I'm spoiling this for some people, but they gave Michael ECT, and all of a sudden all of his memories were gone. No, that's not how ECT works. ECT would just be the short-term memory, like, oh, I don't remember the morning I got my ECT, like I remember having breakfast and walking there, but I don't remember anything after that, right? You're not going to forget your whole family. So yeah, again, don't use TV as a framework for how these things work. So electroconvulsive therapy, ECT, biomedical therapy for severely depressed patients in which brief electrical current is sent through the brain of an anesthetized patient. It's used for depression when the patient does not respond to drug therapy. Although researchers are not sure how ECT works, it may allow neural rewiring and boost neurogenesis. Basically, it's like restarting, rebooting your brain, your computer system. Evidence some memory loss, but no discernible brain damage. And again, this is short-term memory. This is not, I'm going to forget my whole family. I don't know who my wife is or who my mother is. Thank you so much for watching. Make sure you hit that like and subscribe button. Good luck on your exams. If you want a copy of this PowerPoint, then feel free to email me, nursingwithprofessorb@gmail.com, or you can leave a comment below.